Members, good morning. It's the appointed time. We have a quorum. I call to order the special meeting of the panel on health services. We will discuss two items today. One, updates on the development of CUHK Medical Center, and two, Healthcare Manpower Projection 2026. Let's commence the discussion of the first agenda item. I will ask the Secretary to invite representatives from the administration to come inside the conference room. We have in attendance Professor Lo Chung Mao, Secretary for Health, Mr. Raymond Wu, Deputy Secretary for Health 1, Mr. Nicky Ng, Principal Assistant Secretary for Health 4. We have Professor John Chai, Council Chairman of the Chinese University of Hong Kong, Professor Dennis Lo, Vice Chancellor President also of the CUHK, Mr. Dennis Chow, Treasurer CUHK, Professor Philip Chu, Dean, Faculty of Medicine, CUHK, and Dr. Chong Kin Lai, Executive Director and Chief Executive Officer of the CUHK Medical Center. All other LegCo members are invited to join the discussion of this item. Members who wish to speak, please press the Request to Speak button. I will now invite representatives from the administration to brief members on the paper. Thank you, Chair, members. Today, I'm here along with representatives from the CUHK as well as CUHK Medical Center to brief members on the latest updates in relation to the arrangements for the CUHK Medical Center. In 2014, the CUHK proposed to develop a hospital to be operated on a non-profit making basis, and a $4.033 billion loan was granted by the government. It was supposed to be paid back starting from March 2023 for 10 years. But at the launch of the hospital, it was the pandemic, and the medical center had challenges in repaying the loan to the government. So early 2023, an extension application was made to the government. After scrutiny, the Finance Committee of the Legislative Council postponed the repayment arrangement to March 2025. And for the extension, the interest payable will be compensated by providing inpatient services. The government has been paying close attention to the operations of the CUHK Medical Center and has made regular reports along with the CUHK to the Legislative Council. As the hospital has enhanced its operations and cost management, the financial position of the hospital has stabilized and proposed to the government that they want to repay the loan early, and we have received a written notice earlier of this. The CUHK will provide a loan or a guarantee to the CUHK Medical Center so as to consolidate their financial arrangements. They expect to repay on 19th of March 2027 the whole of the loan. And if they can implement the relevant financial arrangements, the government can collect early on the $4.033 billion lent to the medical center. But it does not change the commitment made by the CUHK and the CUHK Medical Center earlier. They still have to exercise the conditions under the modified lend lease as well as the supplementary requirements for them to provide relevant services. In principle, the government agrees to early repayment by the CUHK Medical Center. As for the source of repayment and arrangements, the CUHK and CUHK Medical Center will finalize it later on for the government's consideration. We will maintain close liaison and continue to monitor the CUHK Medical Center's repayment of the loan and their financial arrangements. We will have the hospital authority sign an MOU with the CUHK and CUHK Medical Center in due course. We will make sure to be an important bridge and make sure the CUHK Medical Center can continue to provide good hospital services and exercise their commitment. Thank you, Chair. I will now ask CUHK Medical or CUHK representative to give a PowerPoint presentation. Who's going to speak? Yes, Professor John Chai. Good morning, Chair and members. We would like to thank members and the members of the public for their support of the CUHK Medical Center. We were granted extension twice so that we have more time to repay the loan before 2028. We have been able to enhance our operations and finances. We have consolidated and rationalized our operations. We did see a significant increase in the dedicated funding for CUHK. So the CUHK is planning to make use of part of the loans that were not designated in the fund to be lent to the CUHK Medical Center. We will provide a loan and/or a guarantee to the CUHK Medical Center. We strive to repay early on 19th of March 2027 the whole of the loan lent to us by the government of $4.033 billion, and we will continue to provide services in lieu of interest payable in the extension period. The decision is supported by the board of the CUHK. It has been reached after careful consideration, and we believe we have struck a balance between the interests of the CUHK and CUHK Medical Center as well as the society. We have great optimism about the prospects of the CUHK Medical Center. We have carefully considered the resources available. We believe we can make use of the non-designated loan funding under CUHK to be injected into CUHK Medical Center. We make this arrangement carefully. It does not affect the funds allocated to us under the UGC arrangements. The CUHK Medical Center will continue to act in accordance with the policy direction of the Health Bureau to enhance the public healthcare system and private healthcare system of Hong Kong, and will continue to be the bridge between the two. We will dovetail with the country's strategy to develop high-end healthcare, and we are confident that CUHK Medical Center will be a leader in high-end healthcare in Asia and make contributions to the city and the country. Thank you, Chair. Thank you, Chair. Thank you, Secretary and Council Chairman of the CUHK. All right, let me read out the order in which members are going to speak. Mr. Chong Ho Fong, Ms. Carmen Khan, Mr. Chu Lap Wei, Mr. Adrian Ho, Mr. Chen Pui-Lun, Mr. Yang Wen Kim, Professor Chen Wing Kwong, Ms. Christine Fong, Ms. Chen Ho Yin, Dr. Chen Han Pen, and myself. I will assign a 4-minute time limit, questions and answers included. Mr. Chong Ho Fong. Thank you, Chair. The round table supports this proposal. I wanted to ask about the latest accounts when we only had the paper. Now we have the supplementary paper, and we can see in 2024-2025 for the first 9 months we have a loss of approximately 193,000, and we have later on a loss that is smaller, that is $46 million during the same period in 2025 July 1st and 2026 March 31st. We have seen an utter decline in the losses. I think with this pace next year, it is likely that the CUHK Medical Center will incur a profit. With early repayment of the loan, the CUHK will no longer have to make reports to the panel on health services. But regardless of whether they're borrowing money from the bank or the CUHK, it is still under the CUHK's account. So will the CUHK make a report to the panel on education how the CUHK Medical Center is doing? So whether it is a loan or a guarantee, how much interest expenses will be incurred? What is the difference between the interest payable to the government and to the bank or CUHK? Can you save money in interest costs? So the CUHK Medical Center was not able to repay the loan in 2023. Why did they not propose this option that they have here today then? Thank you, Secretary. All right, I'll ask the CUHK representative to answer this question. All right, perhaps we'll have Professor John Chai answer this question. All right, I'll ask Ms. Dr. Chung Kin Lei to answer this question, the representative from the CUHK Medical Center. All right, the microphone is on. Thank you, Chair and members. I would also like to thank Mr. Chang Ho Feng for his questions. For the CUHK Medical Center, we have seen a gradual improvement in finances starting from 2023, 2024, and 2024 and 2025. In 2023 and 2024, the loss is $245 million, and with the first 9 months of 2026, it's now $46 million. So the improvement in the incurrence of loss is 81%. From November last year to April this year, the EBITDA in the 6 months, for 5 months, we have a positive figure. We believe we have seen the situation to be quite stable, and our operational model has matured. I think this is good. With the number of patients served as well as patient trust, we can see an improvement. The member asked in particular about interest expenditure and the question on panel on education. I'll perhaps let representatives from the CUHK answer the relevant questions. As for why we had to extend repayment in 2023, I believe it was because at the time, actually we were in close communication with the university then, but then the university, whenever they have to allocate funds, they had to be very prudent. And at the time, the operations of the hospital had yet to stabilize. I think what's important is we need to make projections on our repayment ability and whether we could make further financing, and at the time the circumstances probably weren't ideal. I would in particular like to thank the government and the LegCo for granting us an extension for 5 years in total. It has allowed us time to rationalize our operations. We have been able to tide over the challenge of the pandemic. We have now stabilized our operations, and we were able then to have discussions with the school to make financial arrangements. Anything to add from the CUHK representative?
Mr. Dennis Chow can tell us more about the interest expense. Now, for the 5-year extension, the interest rate is based on the long-term return rate of the exchange fund. It's at 5.6%. if we turn to financing or a bank loan, we hope we can lower the interest rate expense by 1.5 to 2 percentage points. And that will make a huge difference, a positive difference for the medical center. Will that figure be reported to the panel on education? If other members have that question down the road, we can invite the officials to give a reply. Next, Ms. Carmen Khan. Thank you. So I have 2 points to make. The first question is for the Council of CUHK. The opening remarks say CUHK has approved the use of uncommitted funds. The paper says the medical center may take out a loan with the CUHK's guarantee. So are we ruling out a loan and we're resorting to the university's own uncommitted funds? Is that the case? So can CUHK confirm that this money is not public money? Instead, it's money from revenue generated by CUHK on its own. So I need to confirm this. Now I turn to my next question. This question is for the Health Bureau. I commend the Bureau's work on supervising the medical center's work. This shows that our monitoring has paid off. So there's early repayment. Still, the medical center will have to fulfill their service obligations. They get concessions from the land lease, so they have to provide the service. So it's service in lieu of interest repayment. I support that. Now on the Memorandum of Understanding, that document under paragraph 15 of the paper says CUHK Medical Center will still have to provide the services in supporting, say, public-private partnerships, and they will also have to deliver on price transparency and also the standardized procedures, as well as greater use of e-health. So I hope the medical center can also take the lead in supporting these initiatives. So we can first hear from the council. Professor John Chai. The question is about a loan from CUHK or a guarantee from CUHK for a loan. We will consider both options, and these options are under consideration. Later, we will report our recommendation to the Bureau. On the finances, every year, UGC-funded universities draw up their financial accounts. Those are public documents that go to the Bureau, and you will see the breakdown in those reports. So can we be sure that the money is not public money? So I can say this money does not involve money from funding provided by the UGC or committed funds. Our provisions come from money generated by universities' own operations. Say this can be donations or investment returns, etc. Some provisions have certain designated purposes, say teaching, research, equipment, or student residences. Those are committed funds. In contrast, uncommitted funds are just money for a rainy day. When there's a use for the money, the council approves the use. Chairman, I think the concern or the question went unanswered. Can we confirm that this does not involve public money? So maybe a written reply would do. What about the secretary? The government and the CUHK Medical Center each plays a different role. For us, at the policy level, we want a non-profit making private hospital offering price transparency. We granted the land at $1,000, so there's a land lease. There's also a service pledge or service deed from CUHK Medical Center. And then for the loan, there's a loan agreement. Later, there was a supplemental service deed and the supplemental loan agreement to extend the repayment. The loan deed allows early repayment. That would discharge the supplemental loan deed. But then for the land lease and the service obligations, those obligations remain in place. So CUHK will continue to play their role. This medical center will remain a non-profit making private teaching hospital. It will also serve as a bridge between public and private healthcare. They will have to offer packaged fees for at least 50% of their services. Now they stand at 53%, meaning they meet the mark. By 2030, they will reach 70%, and that will mean a better outcome for the public on repayment. Based on the written recommendation dated 22nd of April, the university said they will consider two options. First, they can use their own reserves, and they have to make sure this is not money coming from the UGC, meaning the government's money. After all, the government funds universities through the UGC. CUHK has to make sure they're not using money from the UGC. And then they also have to make sure the money is not donations earmarked for specific purposes. Apart from using their own reserves, the university can also consider taking out a bank loan. For the government, we will have to look at the final plan from CUHK. So this can be like refinancing. So they secure another source of funding to repay the government's loan, but we have to make sure the second source is not government money and it does not involve government money. Chairman, the government-appointed director should remain on the board of the medical center. That's my recommendation. Mr. Chui Lapwai, I support the plan to repay the loan early. Paragraph 9C of the paper, and the Secretary has mentioned this, even with the early repayment, the service obligation remains, meaning there will still be roughly 120,749 inpatient bed days. Over 15 years, that's roughly 8,000 hospital bed days per year. From 2023 to 25, there were just 16,841 bed days. So that's short of the target by 30%. Why? What plans does the medical center have to make up for that shortfall? Secretary, this has to do with extending or deferring the repayment from 2023 to 2028, so that's pushing the date back by 5 years, and that's why interest accrues based on the rate of the exchange fund. And that's why we arrived at this equivalent of 120,000 hospital bed days. On the provision of services, that is spread over 15 years. In the early days of the medical center, the institution was more limited in its capacity. So in the early days, it provided less services because of a shortage of manpower. But as the hospital grew, it could provide more services. Now they're providing services exceeding the requirement. Any follow-up? No. Mr. Adrian Ho. I support the early repayment plan. I do have some questions. The creditor is less of an issue. The bigger question is the hospital's revenue. At $4 billion, the revenue will be able to cover the principal. At $6 billion, it will be able to cover the principal plus interest. So I wonder, when do we expect to reach those levels of income based on the latest timetable? If the final decision is to take out a bank loan, banks are private players. If banks are the creditor, they may be less accommodating. They will take a purely commercial approach to assessing the hospital's ability to repay. So I wonder if the government has assessed the current cash flow and current operation. Will the hospital be able to keep up with the interest payment? After all, interest rates may rise in the future. The paper also says the medical center can offer private healthcare services at an affordable price. But if business slows down the road, private businesses can raise their prices. So if businesses slow in the future, will prices go up? And after the price hike, will those prices remain affordable for the public? Secretary, the medical center can take the questions. Dr. Chong. Thank you. I thank the member for his concern. So do we. The future of the hospital matters. We shared some figures. We talked about our goals. We haven't reached our goals yet, but reaching those goals is by no means impossible. We are confident for a reason. We still have capacity to further expand our operating theaters and beds so we can further increase our revenue. We also have strategies. To give full play to our edge in clinical services. We have 6 key specialties. We have an edge: oncology, heart diseases, ear, nose, throat, orthopedics, and neurosurgery. We will double down on these 6 areas. On price adjustments, we will keep the fees at an acceptable level. We will continue to offer price transparency, reliable services, and affordable services. This will be vital for our future. We will expand the network of doctors. We will expand collaboration with insurers. We will tap the Asian Greater Bay Area. We will pursue integrated Chinese-Western integration. These strategies will enhance our brand and our operation, and we will continue with the work on cost control. And that's something we did over the past year. We looked at our approach to budgeting and projection. I adopted this new approach when I took the job. I looked at the hospital's future. Over the past 9 months, I can say with confidence that we can get a picture, an accurate picture of the hospital's future. We have a projection for the next 10 years, a proactive and also prudent forecast. We are confident that with the full launch of our services in 4 to 5 years' time, we will be able to start repaying not just the interest but also the principal. So I hope that reassures the member.
多謝主席。
Next, Mr. Champulang. Thank you, Chair. First of all, I welcome the early repayment arrangement by the CUHK. I think it also shows how the CUHK Medical Center is confident in its future operations. I have two questions. First, for the interest payable during the extension period, it is to be paid back by services provided. And as the Secretary said, we should be able to see the CUHK Medical Center fulfill the service places of 8,000 per year. But we're talking about a long period of 15 years. There may be changes if the CUHK Medical Center cannot meet the service requirement within 15 years. Will we extend the period for them to fulfill the obligation, or what other arrangement can we implement? Also, every year will the government publish the relevant figures to see how the CUHK Medical Center is doing every year to meet the relevant service requirement. About the package charging arrangements, the insurance sector very much welcome this. It also helps control medical expenses. And it is said in future, 70% of the services will provide package charging. But I'm afraid a challenge is doctors do not like this arrangement. Doctors' fees, if it cannot be determined flexibly, should be fixed. So with more items charged as packages, how can we attract more doctors to provide their services in packages? Thank you. Let me first talk about the supplemental service deed. With the CUHK Medical Center applying for a repayment extension, they want to pay back interest by providing services. It is a win-win for all, because for the CUHK, they have a smaller payment obligation, and for the HA, we have the CUHK Medical Center shouldering the burden, and for the public, they can also benefit from the services of the CUHK Medical Center at hospital authority prices. We have been discussing with the CUHK Medical Center, and we agree that the CUHK Medical Center will not pay the interests within the 5 years, that is between 2022 to 2027, in money. They will provide services in lieu of the interest. They can provide outpatient services, they can provide diagnostics, imaging services, they may also provide inpatient services. So we will also take into account the cost of the hospital authority for the next 15 years, and I believe the rate is 4.75% each year. The figure is actually quite precise. The CUHK Medical Center will continue to provide services. We will continue to pay attention to the situation. The CUHK Medical Center may repay the interest payable in money in future. We will consider this if they propose so. But as Mr. Chen said, we want to make sure the CUHK Medical Center remain committed in making the relevant service obligation. Mr. Yang Wing-Kit. Thank you, Chair. CUHKers all along are rising up to the challenges, and we are responsible. And as a CUHKer myself, I support the proposal, but I also have some reservations about the repayment option. The CUHK representatives made a report and they said they thank the government and Legislative Council for their support. But then they say because the government is charging them higher interest rates, they want to repay the loan now so they can save interest costs by 1 to 1.5%. If people repay loans early on with banks, there is an early repayment charge. The Secretary charged this. Even a 3% charge is not too much to ask, because if we're talking about 10 years, they are repaying interest in 5%. It will benefit the government and the public. If they're trying to save interest with this option, it is not how CUHKers behave. I think they should pay an early repayment charge. Thank you. Secretary, I will let the CUHK representatives answer some of the questions. For the loan agreement, I would like to emphasize that we follow the conditions of the loan agreement. Like Mr. Young's example, if we are borrowing a mortgage from the bank, if you have to make a further drawdown, there will be other terms. And if there is no term on early repayment charge early on, then we can't really add that now. And with the interest rate being linked to exchange funds rate, we will not incur a loss. And the interest rate was quite high before. It's 5.6%. And if you have borrowed money from the bank, this is a relatively high interest rate, as you should know. For the first 5 years, the loan is interest-free, and this is all in the loan agreement. And later on, an interest rate linked to exchange fund rate will be charged. Let's understand that the CUHK Medical Center is not a commercial organized or company. I don't agree with what the members said about we are losing out because the CUHK Medical Center is making an early repayment of the loan. And in fact, if they are just like working with banks, they are doing a remortgage, we are not losing out. We can get the funds back, and we can profit that by, for example, placing that with the exchange fund. With the repayment arrangement, the CUHK will benefit. They will not be charged as high of an interest rate. There's also some flexibility with the repayment. Before, they were supposed to repay every year approximately $500 million. We don't know how the CUHK will do in future, but let me say this: we have complied with all the conditions under the loan agreement. Thank you. Professor Chen Wing-Kong, thank you, Chair. I think with CUHK Medical Center's proposal for early repayment, I think they are showing that they are responsible. I would like to follow up on some aspects, however. We would have the CUHK lending money to the CUHK Medical Center. Will the loan be made in full from the CUHK, or is it part of it? Is it that part of it will come from the bank? What is the proposed ratio if both options are opted for? I believe people remember just last year on 14th of February when they're making a report, they are still striving for member support to extend the loan. They don't even have the money to pay back interest with their investments. So why is it that just after a year there is such a drastic change that they can repay the whole of the loan? I also want to ask, how can we make sure the CUHK Medical Center will still be operating on a non-profit making basis after repaying the loan? Can the CUHK and CUHK Medical Center pledge to the public that they will not be profit making and they are committed to still providing quality private medical services at affordable prices? Thank you. Secretary, let me answer the second question first about how the government can ensure the CUHK Medical Center provides services as agreed. Well, we only deal with the loan agreement and the supplemental service deed. As I said earlier, they will pay in lieu of interest supplementary services. They will continue to provide that even with early repayment of the loan. We will also make sure the CUHK Medical Center and the Hospital Authority will sign an MOU to make sure the CUHK Medical Center will continue to operate as a private hospital that is operating on a non-profit making basis, and that it will be a bridge between the public and private healthcare systems. In fact, in the service deed as well as the supplemental service deed, with public healthcare services and provided by the CUHK Medical Center, they are heavily subsidized. And we can set out the details in the MOU. In fact, the CUHK Medical Center can probably have more areas for cooperation with the hospital authority in future. I'll now let the CUHK representatives supplement my reply. Thank you. Professor John Chai. Thank you, Chair. Thank you, Member, for the question. Let me first answer why we asked for an extension last year and a few years ago. We actually received valuable feedback from members when we made reports to the Council. And one of the feedback was we had to enhance governance. And in fact, we have made a number of improvements. We have now the Vice Chancellor now on the chairman of the board of the CUHK Medical Center, and Dr. Chung Kin Lai was also appointed just last year. With Dr. Chung Kin Lai taking office, we have seen changes in the membership of the board of the CUHK Medical Center as well as senior management. Basically, we have now confirmed the operational model of the CUHK Medical Center to be feasible. If the operations are not feasible, the CUHK would not want to put money into the CUHK Medical Center. And the CUHK Medical Center always has the support of the CUHK. The vision of establishing the CUHK Medical Center is to make use of the medical center to serve the public as a teaching and operational hospital. We have also appointed directors of a CUHK Medical Center to the board. With interest payable in the extension period, if we do not fulfill the service obligation, the CUHK Medical Center would have to pay back the interest or perform other services. At this stage, we can see in different areas we have met the performance targets we had in mind, and it has really instilled confidence in the council of the CUHK. We now have a vote of confidence in the CUHK Medical Center. That's my reply. Thank you.
Next, Ms. Christine Fong. Thank you. Losses have narrowed by 67%, roughly $46 million last year. And then the medical center also proposed to repay the $4.033 billion loan in full by March next year. That's welcome news. This also points to confidence in CUHK's Faculty of Medicine and Medical Center. I'm also a graduate of CUHK. I'm proud of that. Now, a non-profit making private teaching hospital will have to stay financially viable before it can proceed with teaching and also engage in research for public health. I support the direction. I do have some questions. I'm from the New Territories Southeast constituency. Some residents from Ma On Shan told me they decided against going to this medical center for a reason. The medical center is near the university station, but then for minor surgeries, the fees are on the high side. That's unaffordable for the general public. Can the hospital and the bureau review such fees? There are packaged charges for oncology and orthopedics. When we compare the fees with those of other hospitals, such as Matilda Hospital, how much cheaper in percentage terms are the services at CUHK Medical Center? How do you strike a balance between the fees and the non-profit making purpose? You have to stay competitive without being a profit-making body. It's a tough balancing act. Many people were not aware of the round-the-clock services and also the integrated Chinese Western medicine services, so the medical center has yet to give full play to its edge. The medical center just told us they would talk to the insurance sector about the packages and also engage in publicity. Some in the middle class in Hong Kong don't go to public hospitals. So I wonder what role will the medical center play in schemes like the chronic disease co-care pilot scheme. The secretary said they would continue to monitor different aspects such as the service deed and the lease conditions. Will these matters be reported to a particular panel at LegCo? Before we come to the response, I want to say a few words. We can talk about the fees. But on comparing the fees of one hospital with that of another, I don't think that is not a matter for public discussion here when you're naming particular private hospitals. Secretary. Packaged charges have merit. Packages offer safeguards for the public so that they go to a hospital knowing how much the service will cost, instead of leaving it to the doctor to dictate the fees as you get in an omakase arrangement as a restaurant. packaged charging also avoids excessive and unnecessary medical services like needless checks and drugs. So that's the merit of packaged charging. We hope this can also mitigate medical inflation. And we're following up on this matter with different hospitals. Part of the service deed with the CUHK Medical Center is that for day procedures and surgeries, there will be different packaged charges. And this is a requirement that is part of the service deed for the medical center. Every year, the medical center has to report its performance to this panel because of the loan. Once the loan is repaid in full, there will be no more obligation for them to do the annual reporting. But the government is also involved in other ways. If there's something that should be reported, or if members want to find out something about the medical center can come to the panel and brief members on those points. As for the other questions, the university can take those questions. Professor Chai, Dr. Chong will take the questions. Thank you. We value the comments of the residents of not only New Territories East, but also of residents across the city. But people in Mount Anshan are really close by, so we value their comments. The member brought up publicity. Internally, we're working on service quality. When I took over the job, I heard about issues concerning service quality and fees. That's why there were rounds of fee adjustment. It may not be very productive to compare our hospital with other rivals, apple to apple, but we want to return to our original purpose, price transparency. We did not have all the information, so we stuck to a formula. But that did not meet the market's needs. After all these changes to the fees, we are now much better placed in serving our purpose. We now have round-the-clock services. In our third round of fee adjustments, we did some real work. We simplified our fees. The biggest unknown factor in the fee is the medication. The fee may turn out to be twice as much as before after you get the drugs. So for common diseases like gastroenteritis and upper respiratory tract infection, we now offer packaged charges for drugs over 3 days or drugs over 5 days. And the public finds that helpful. At the A&E, there were 120 to 140 days per day. Now the number stands at 180. During the long weekend, we got 250 visitors at the hospital per day. There's something I know. It's hard to access healthcare over long weekends or holidays because doctors also go on leave. I want our hospital to be able to help the public and people can access healthcare here. Ms. Chen Haoyan. The CUHK Medical Center plays a key role in public and private healthcare because this is a non-profit making teaching hospital. I support this hospital. It offers quality care. This time, the medical center wants to repay the loan early. I support that, but I want to get some clarity over the figures. In February 2023 and in February 2025, we discussed deferring the repayment. Now, in May 2026, I know we got a reply from the university, but some questions went unanswered. It's just over a year from the last meeting. We were still talking about the loan, and now we're talking about early repayment. What changed? Is it because a sudden surge in your reserves, or is it because a huge increase in donations? We're talking about public funds. We spent a good deal of time on the finances. What changed over the past year? So how much do you have in reserves in terms of uncommitted funds? Why just repay the principal instead of repaying both the principal and the interest? The hospital also told us they still have half the capacity to expand. With more wards and beds, you can provide more services, and that means more revenue. How long will the capacity last? The paper is silent on repaying the interest. In over 15 years, the hospital has to provide 120,000 bed days. But over 2 years from 2023 to 2025, the hospital only provided 16,000 or so bed days. At that rate, you are far below the level where you can provide all the days committed. Now, this is supposed to be a non-profit making private hospital. Will the fees be reviewed? I know there were changes, but then in the next 1, 3, or 5 years, are there further plans to raise or lower fees? Some questions were addressed. Those questions were unaddressed. The question about service in lieu of interest was answered. Secretary, this arrangement offers a better outcome for all. Over 15 years, they will provide over 120,000 bed days. That's good for the patients of the hospital authority. That also means a better outcome for other parties. On the repayment period, the services will be provided over 15 years. They're now only at 50% of their capacity. In the early days, there were constraints, so we set a low target. Over 2 years, they provided 16,000 beds. That is already above the original target. Once the capacity is ramped up with more beds, more services will come on stream. As for the other questions, they will go to the university. Professor John Chai. On repayment. In March last year, we were discussing the 2+3 proposal. There was a gap, and back then we talked about a gap projected for 2028. At that point, we expected a gap in the money. So we pledged to review different financing options. Back then, Mr. Norman Chen mentioned seeking out patient capital and other funding models, such as dipping into the university's reserves or getting the university to act as a guarantor. So we're simply now acting on the plans we discussed last year on why we can manage to do this. We are turning things around, though not exactly a huge change. we broke even for EBITDA. That's because of the suggestions from members: stronger governance, better management, reestablishing our operating model. We delivered on that, and that also gives CUHK confidence, and I hope members can also be confident in the hospital. Thank you.
Dr. Chen Hanpan. Thank you. Chair, I would like to declare I am a council member of the CUHK. From what I heard, most members support the early repayment proposal. It shows the CUHK is being responsible, and it is creating a win-win situation. The proposal is pragmatic and reasonable. At the launch of the CUHK Medical Center, because it was the pandemic, the CUHK Medical Center was struggling and applied for an extension in repayment. I heard earlier the interest payable will be paid back by service provision. I think this is innovative and that can benefit the public. Before I was a council member of the CUHK, I believe members understand that there is a new governance model at the university, and the CUHK Medical Center is the same. They have enhanced governance, and we can see with the new team they have achieved great results with their efforts. They would continue to have package charging. Before, when we talked about having package charging, it is to protect interests of the public, and as the secretary said, this should enhance transparency, and this is what is practiced in the CUHK Medical Center in future, and that should continue to protect the interests of the public. Even though they have repaid the loan in future, they should still show such commitment to the public. If a hospital is shouldering a heavy financial burden, it can seriously affect its operations. If we can alleviate that burden so that the hospital have more resources, perhaps to lower the medical fees, as some members suggested, Dr. Chung suggested to Dr. Chung, I think for the hospital, for the students, for the university, or for the public, this can be beneficial. I think we are giving more room for the hospital to grow, and I think in the end it will be a win-win situation for all, including the public. So I hope members will support the proposal, and with the operational model of a CUHK Medical Center, it may encourage other private sector hospitals to adopt the same model when they see the operations of the CUHK Medical Center being quite successful. We will also have expertise as well as training provided by the hospital, and I appreciate that. I actually don't have any questions, Chair. I only have comments. All right, any response from the administration? None? Thank you. Mr. Shu Kafei. Thank you, Chair. This is the second panel on health services meeting of the month, and this is a special meeting. We are to discuss development of the CUHK Medical Center. Chair, right now is 11:49. We commenced discussion of this item at 10:45. So we have been discussing this item for 1 hour and 4 minutes, and there are 2 other members waiting to speak. I believe members of the public and members attach great importance to this issue, which is why, even with some time left last time, we chose not to discuss this item at the last meeting, and we commenced discussion of this item today. I do want to apologize to the representatives from the administration of CUHK today for our time management on the last occasion. Now, they are making regular reports before because they may have to ask for an extension, or if they are unable to repay the interest or the capital. In future, with they having repaid the loan, will they still be able to make reports? Actually, the Secretary answered this question earlier. We would have the CUHK Medical Center repay the loan, so we will no longer make annual reports to the council on this. But then we understand, as a private hospital that is providing some public healthcare services, I believe, if necessary, the CUHK Medical Center is more than willing to join this discussion of this issue should there be discussion on this item. Thank you. I think with hospital operations, as laymen, we don't really know specifically how we can enhance the operations, but we can perhaps provide feedback from a commercial perspective. And in fact, Dr. Chung Kin Lai's points are quite valid. He would make use of scientific data, and they would scrutinize the operations in the private sector and make adjustments to the operations. I believe with this perspective, the CUHK Medical Center will resolve their issues. I am very confident, and they will no longer have to make reports, and they will no longer need feedback from us laymen. But with what Mr. Yang Wen-kit said, I want to say something. With the government lending money to CUHK, we are not trying to earn interest income. We want to facilitate development of the CUHK Medical Center. Basically, I disagree with Mr. Yang Wen-kit. We are not supporting this proposal simply because the CUHK Medical Center will be saving in interest costs. And I think there are some valid points made by Ms. Chen Hoi-yen as well. I think with a service deed to alleviate the burden on public healthcare system, it can really benefit us in the end. So I support the proposal. Thank you. Any response from the administration? None. Thank you, Mr. Jonathan Leung. Thank you, Chair. I would like to declare an interest. I'm also a council member of the CUHK. Speaking from the perspective of a LegCo member on early repayment of the loan, there were actually many media reports before about the finances of the CUHK Medical Center. Many members were concerned about the financial position of the medical center, and we have seen with continuous reforms, they now have a profit for the last 6 months. I think that shows the CUHK Medical Center is doing well, and we already have, in a way, penalty to be paid for the extension in the loan agreement. I've heard what other members say, but I think the CUHK Medical Center is special in a way that it is trying to be a bridge between the public and private healthcare systems. And I would say the government is not lending money to the CUHK Medical Center for interest income. I think the Secretary has made a valid point. It is creating a win-win situation for all. And with us having 120,000 beds with the CUHK Medical Center providing such services in lieu of interest, I think it is good. It is meeting the gap in service provision. Some are concerned that regular reports will no longer be made by CUHK Medical Center, but I think we can rest assured because the Secretary and the Health Bureau in general will continue to make sure the CUHK Medical Center adheres to its vision. So I support the proposal. Thank you, Chair. Any response from the administration? I believe if necessary, we may consider making reports to the panel on health services, for example, on medical reforms or how we can enhance transparency in fee structure of private hospitals. Thank you. All right, it's now my turn to speak. Some members have asked if the government will appoint a director from the government to the management of the CUHK Medical Center. I can see the CUHK Medical Center will do that. And I also note for the operations of the CUHK Medical Center, right now we do have cross-boundary healthcare services or ambulance services in particular. In future, will we have private hospitals that provide A&E services that can receive cross-boundary cases? So that essentially provides an additional area of operation for the CUHK Medical Center. Thank you. Secretary, before the CUHK Medical Center repays the whole of the loan before 19th of July 2027, we had several directors, for example, Dr. Tan Hin-lei, as a council member of the CUHK. They have played an important role of the bridge between CUHK and the government. It has really helped us understand better the financial position and service development of the CUHK Medical Center. We will continue to work with the CUHK Medical Center and Dr. Harry Chen to make sure he will continue to be part of the board of the CUHK Medical Center. As for cross-boundary ambulance services, this is relevant to the government policy for cross-boundary healthcare. We actually made a breakthrough by providing point-to-point ambulance services. So basically, the arrangement involves designated hospitals in the mainland and transport between them and designated hospitals in Hong Kong. The Hospital Authority, as the largest health body in Hong Kong, would make relevant arrangements. We do have pilot arrangements right now in place, allowing us to have good control of the arrangements. With the patients arriving at Hospital Authority hospitals, they can seek transfers to private hospitals such as the CUHK Medical Center. As for whether to designate the CUHK Medical Center as a hospital, we will see if we can extend the arrangements in general in future. Thank you, Chair. Thank you. representative from the administration, CUHK and CUHK Medical Center. We'll end the discussion here. We'll move on to the next agenda item, Healthcare Manpower Projection 2026. Let's invite representatives of the administration to come inside the conference room.
Joining us for this item are the Secretary and also Ms. Ling Mek, Deputy Secretary for Health, Dr. Pauline Wu, Chief Health Statistician, Dr. Wang Yuchong, Director from the Hospital Authority, Dr. Jackie Leung, Assistant Director of Health, and Dr. Minky Wen, Senior Health Statistician. Members who wish to speak, please press the Request to Speak button. There will be slides to go along with the presentation. Over to the administration. Chairman, members, healthcare puts people first. It's not just about patients, it's also about the healthcare professionals providing the services. Healthcare is a knowledge-intensive and practice-based area. The number of healthcare professionals determine the quality and safety of care. The government attaches importance to the nurturing of healthcare professionals. In 2017, a recommendation came out from the report of the Strategic Review on Healthcare Manpower Planning and Professional Development. The approach was to tie in with the triennial planning cycle of University Grants Committee. So we conduct healthcare manpower projections every 3 years, covering 13 healthcare professions. In mid-2024, we announced the findings of the last projection. That projection was based on 2019, before COVID struck. With demographic shift, the rise of chronic illnesses, and deepening healthcare reforms such as primary healthcare, our medical healthcare hub, as well as cross-boundary healthcare services and innovations, we will need a new round of manpower projection for the short, medium, and long-term plan so that we come up with the policies for this area. This is to maintain Hong Kong's highly efficient medical services in line with other broader healthcare reform and to cope with healthcare emergencies. For the shortage of manpower in the public healthcare system, we also launched measures to retain talent and also attract talent. The wastage rate at the Hospital Authority has fallen for 4 years in a row. In 2023 to 2023, the number of doctors actually went back up over 2022 to 23 and 2023 to 24. So the waiting time at the public healthcare system will go down. Still, we have vacancies for doctors and nurses in the public system. The vacancies make up roughly 10% in the public healthcare system. The demand will only grow up. The shortage of public healthcare manpower is a fact we have to acknowledge. The Hospital Authority gives priority to local healthcare graduates. With that in mind, we also admit non-locally trained healthcare professionals. As at the end of March this year, non-locally trained doctors and nurses made up roughly 520. They got the local they were locally approved and they can ease the shortage. But they make up only 3% of all doctors in Hong Kong and 0.7% of all registered nurses. The government has commissioned the Hospital Authority to conduct a new round of healthcare manpower planning. We will adopt 2024 as the base year. The projection will cover the next 20 years. Over the past year, the team has held meetings with 100 groups from different healthcare bodies, where the team listened to the views. The quality of our talent will make a difference for the quality of care in the future. The public's well-being is at stake, and this will also have wider implications. The healthcare manpower projection will be based on a scientific method and statistics. But this is also about planning for public policy. We will analyze known figures. We will also have to cover unknown factors such as future demographics, innovation, and policy. We will have to make assumptions, and we will have to extrapolate so that we can come to a model on quantities. It's an art and a science. There are many unknown factors. There will be room for error. More reliable and more precise projection such that the results can reflect the future manpower position of each medical profession will require input from all sectors. So I hope we can have a focused discussion on the focus, the assumptions, and what we have to look out for in the future, so that we can all improve the methodology, so that we can come up with a more accurate projection for the next 20 years. Dr. Pauline Wu, Chief Health Statistician, will tell members in greater detail the model for projecting the demand and supply. And then my team and I will be happy to take questions. Thank you. Dr. Wu. We'll have to switch on her microphone. It's on. Thank you. And I also thank the Secretary for his opening remarks. I will take members through Healthcare Manpower Projection 2026 with the slides. First, the framework for the projection. We take 2024 as the base year. We will cover 13 healthcare professions subject to statutory projection. We will cover the demand and supply over the next 10 to 20 years. That means for each of the 13 professions, there will be a separate model for the years 2035 and 2040. With the projection for demand and supply, we will also incorporate the known gaps based on the base year, and then we will arrive at the projections. We can look at the balance. When the demand is more or less the same as the supply, we would say there is, broadly speaking, an equilibrium. On the left, when there is more demand than supply, there's a shortage. When it's the opposite, we would say we have enough manpower. Now, the purpose of the projection, as the Secretary said, this is about tying in with the triennial planning cycles of the University Grants Committee when it comes to subsidized healthcare training places. The next cycle will cover 2028 to 2031. We hope that this projection can help the government and relevant organizations by providing a source of reference so that they can formulate targeted healthcare manpower strategies that's to meet future public needs for healthcare. We will work on a projection for demand and for supply. First, on the demand side, for every healthcare profession, we will perform projection covering each body, meaning the hospital authority, the Department of Health, and also other government departments. For private bodies, we will cover private hospitals and clinics. We will also cover social welfare organizations and academic institutions. We will look at factors that will have a major impact on manpower. The demand is mostly driven by the population. So we will look at the official figures from the census and statistics departments. We'll look at figures showing the aging population and other demographic shifts. Chronic diseases are prevalent, so we will look at the growth in the population with such chronic diseases. We also look at the growth in the number of students in healthcare disciplines. Based on the growth in such population, we proceed to the projection. The hospital authority has the detailed figures. We have the parameters. This means the usage rate of different services such as inpatient care, outpatient care, operating theaters, and accident and emergency departments. With these metrics, and we combine that with the growth in population, we arrive at the projection. So how do we go from that to the future demand? We look at the annual usage levels. So we look at the population growth, we arrive at the demand in the future, and then we arrive at the manpower needed. We can factor in the population growth and the figures about chronic diseases. There are other factors as well, such as known policies and measures. We put those blueprints into the model. And for elderly care and community services, there are government proposals and also plans to strengthen primary health care, enhancements to dental services, expansion of private hospitals, and also the commissioning of the Chinese Medicine Hospital. We factor in all these factors into our model. There's a major assumption in our projection. We assume that the future growth in demand and the manpower demand will not be held back by facilities and population. So the basis of the projection is the population. Now I want to cover the sources of our data. The hospital authority has detailed figures on the usage of services. The detail can be as granular as inpatient care, operating theaters, and outpatient care. Here, the focus is on healthcare manpower projection, so we need the figures on the healthcare professionals. We have access to the figures on the usage of clinics as well as the healthcare professionals under the Department of Health, so we can put the figures in our model. Private hospitals also offer inpatient care and outpatient care. We incorporate those figures into our model. The usage of healthcare vouchers for the elderly is also factored in. We also rely on the official figures from the Census and Statistics Department. We rely on the figures from the population projection from the CNSD back from 2021. The thematic household survey will also helpful in terms of the healthcare related data. That's because That survey covers the use of private healthcare services, and that's helpful for us. We're commissioned by the Health Bureau for this projection. We will also have access to information on healthcare professionals from other bureaus. Now I have covered the model and the projection. There will also be a separate projection for the supply of manpower in healthcare. For each healthcare profession, there will be a separate projection. We take 2024 as the base year. So we will rely on the number of registered professionals in each such field as at the end of 2024. But that number is not good enough. But some people work on a full-time basis, while others may be part-timers. So we look at the number as full-time equivalents. So a single professional may not be the same as one FTE. Once we have the number from 2024, we look at the staff movement in terms of inflow. This is determined by the increase in training places. We look at new registrations, people who are locally trained and non-locally trained. We look at the special registration, general registration, and limited registration. And then we minus the leavers. The biggest leavers are those who retire. And then we also look at leavers who decided not to renew their registration.
With these parameters set, we will project manpower for the next 10 to 20 years. There is an important assumption here. We assume for different medical professions, the training and registration system and the work model will remain constant. Let me talk about the major data sources for the health manpower projection. We have some information on training from the UGC and Education Bureau, information on subsidized and non-UGC subsidized courses, the number of students, for example. For different medical professions, there are different hours and work models. There are also different ratio of males and females, which is why we would also rely on other surveys of the hospital authority as well as, say, the Chinese Medicine Practitioners Board. I will not talk about specifically for each medical profession which data sources we will refer to. Basically, as the Secretary said, since last November, we have held consultation sessions with different bodies and stakeholders. We collected feedback from stakeholders and discussed with them what factors may affect future supply and demand of healthcare manpower. With the consultations and meetings with stakeholders, we have collected much data. The data can be of great reference for formulating the healthcare manpower projections. For the next step, we will incorporate relevant feedback to finalize the relevant projections. We expect to complete the work on the healthcare manpower projections by first half of 2027. The findings will be announced in the middle of next year. That's it for my presentation. Thank you. Thank you. I read out the order in which members are going to speak. Ms. Chen Hao-yen, Professor Chen Wing-Kong, Mr. Chen Hop-Fong, Ms. Jovi Chen, Mr. Duncan Chu, and myself. Outside the 4-minute time limit, questions and answers included. Ms. Chen Hao-yen. Thank you, Chair. We have the healthcare manpower projections carried out on the basis of the 2017 report, and we have covered the medical professions that require registration at law, but we have implemented many medical reforms in recent years, and we have seen some medical professions that have great demand and play an important role, but they are not included in the healthcare manpower projections. For example, dental hygienists are included, but then dental therapists are not. Right now, dental therapists only work in the government, but with the amendments made to the dentist registration ordinance, in the next 3 years, we will have dental therapists practicing in the private sector as well. So we would have in future the developments, more dental hygienists perhaps studying to become dental therapists. So on top of dental hygienists, do we need to project the demand and supply for dental therapists as well? And should we make sure there is a pathway, a clear pathway for training and development of dental therapists? If we include dental therapists in the projections, if the dental therapists can practice in the private sector, it can also affect the demand and supply for dental hygienists. If we make the projections later, will it be too late? The CUHK and Hong Kong U did the projections before, but Hospital Authority actually plays an important role in the projections, and we can see there is great shortage of nurses. The Hospital Authority notes the figure, but then we have seen even greater gap now with senior nurses not having their contract renewed, or they are no longer engaged for part-time work. Can we make sure adjustments to manpower can be made when there is a serious shortage of nurses, instead of just leaving it be with nurses saying that they are not valued? Thank you. Secretary. Thank you. With the amendments made to the dentist registration ordinance for dental hygienists and dental therapists, in future they have to be registered by law. We do not have the projections covering dental therapists because right now dental therapists only work in the Department of Health. So we do not need territory-wide projections for dental therapists. In future, dental therapists may work in the private sector, and therefore we consider including dental care professionals in the healthcare manpower projections. As for the role of the Hospital Authority in the healthcare manpower projection, I would like to make clear one point. They are not making the manpower projections for themselves. They are making the projections for the territory. They want to make sure we have a pool of talents, and they have the relevant statistical data because most patients are treated in the public healthcare system. But the healthcare manpower projections are not just for the public sector, but also for the private sector. So we have here today, as you could see, statisticians as well. And they are compiling statistics for the whole of Hong Kong. As for manpower for nurses in the hospital authority, the hospital authority has an establishment and they have a regime for them to determine how much manpower they need. And even with a decline in wastage, there is still approximately 40% shortage. We actually answered a relevant question before. With a decline in wastage, we have more full-time nurses. The hospital authority does not need as many part-time nurses because they would prefer full-time nurses that can provide continuous services. For part-time nurses, they may not be able to provide services at a time needed. Their knowledge and skills may not be those required by the hospital authority. We actually have a very high ratio of nurses to population. We have for every 1,000 people 10 nurses, whereas for doctors it's just 2.2. So we have a ratio of 1 to 4.4 to 4.5. In the mainland, it's 1 to 1 or 1 to 3 or at most 1 to 4. So we only have shortage in specific areas of the hospital authority services, in particular inpatient services. For nurses working night shifts, we have a significant shortage. So the hospital authority is looking into how for the specific areas where there is serious shortage and specialist services, for example, we were able to retain relevant talents. Thank you. Professor Chen Kong, Deputy Chairman. Thank you, Chair. I would like to follow up on some specific issues. In paragraph 6, it says, in particular, we have some demands for maintaining a healthcare talent pool, but then we have all along a serious shortage in the public healthcare system. Should we include in our manpower projections a reasonable manning ratio for the public healthcare system and have that as a premise in making the projections so that we can have better plans? For the manpower projections for Chinese medicine practitioners, we only have 3 local universities operating relevant courses. That is bachelor's degree courses for Chinese medicine. In the mainland, there are 31 universities operating full-time courses in Chinese medicine. According to the administration's reply to my special finance committee question before, we only have 58 to 82 graduating from such courses and registering locally. We have 159 to 234 students admitted via non-local pathways. I want to ask if the administration has considered how non-locally trained graduates would affect the supply and demand of CMPs locally. I want to ask, we have local training that would allow students to have unique advantages in bringing Chinese medicine global. So can you consider doing more in local training? Thank you, Chair. For manpower projections, we do want to serve the public, and with the healthcare manpower projections, we look at the whole territory, supply and demand. We will not draw a line here. Right now, we do see how many talents are trained by local universities, but they do not necessarily serve in the public sector. It's just like nurses. They may work anywhere they want. They may work in the public sector, the private sector, or even in residential care homes for the elderly. Some professionals may choose not to practice at all. So with the manpower projections, we are not limited to the supply and demand for hospital authorities services, as people can choose to work anywhere they want. As for CMPs, we have 31 universities in the mainland as they will take the practicing examination just like local students do. This standard is unified. The mainland universities have great strengths in Chinese medicine, and we have already 31 universities recognized, and students from these universities can take the practicing examination in Hong Kong. You already provided some of the data, members, but basically 300 graduates can pass the practicing examination, 1/3 of them local graduates, 2/3 of them mainland graduates. But many of the mainland graduates are Hong Kongers who studied in the mainland, and they are coming back to work in Hong Kong. As for whether we'll cover them in the manpower projections, of course we will. We will consider how many will pass the practicing examination in our projections for CMP. As for local universities training in different languages, we do have such training in Hong Kong, but then considering the history of Chinese medicine, there are many jargons in Chinese. I believe we would prefer Chinese as the medium of communication. Cantonese and Putonghua would work fine. Thank you, Chair.
Mr. Chen Hockfong, I have some questions. This is about the training plans of universities. That's why we conduct a projection every 3 years. But I'm looking at the annex. Most of these professions require training over more than 3 years. Some require 6 years. A medical student has to go through 6 years of training. Can we extend the interval of projections? Universities now offer 4-year education. Medical schools last even longer. Have we considered adjusting the interval of projections, or is the current approach the best one we have? Now, we're not adopting a rolling basis for projection. Will a rolling basis produce more accurate projections? Things can change between projections, and then it will take a long time to adjust projections. Will we consider adopting a rolling basis? Now, the manpower need is based on the demand. We're talking about the number of professionals we need rather than the indicators. Now, for public hospitals, people have to wait 80 plus or 100 weeks before seeing a doctor for the first time. Can we have goals such as cutting the waiting time for the first consultation to maybe 10 weeks or 8 weeks, and then people can tell whether the projection is accurate? The talk of manpower planning makes little sense to me. The government may see maintaining the waiting time at 100 weeks is fine, but that doesn't work for the public. Secretary, there's a reason that the manpower projection producer makes little sense to the member. As I said, it's an art and a science. As our chief statistician said, when we say science, it's about working with the existing data. It's about the figures of the usage at the hospital authority, the capacity of private hospitals, and the manpower. We have the data. How do we extrapolate about the future? There are many unknowns about the future. There is policy. There's the career preferences of professionals and also technology. And it also depends on how you compute the figures. That's why we want to hear from members about what assumptions we should factor in and how we should crunch the numbers. The member asked why adopt this 3-year cycle. That's because it's in keeping with the UGC's approach. They do triennial planning to adjust the admission numbers for undergraduates. We look at the admission of students. This student may take 3 to 5 years to graduate. It doesn't matter because that student will be part of the projection. That's why we are not worried about how long the training lasts. Since the service will be adjusted every 3 years, we want to get the projection right before that change so that the UGC can make more informed adjustments to their admission. Once we admit the student, we will have the duty to train up the student and turn them into a professional. It's up to the student which profession this student enters. I can see where you're coming from about the point about the rolling basis. There are so many uncertainties. What if things change between projections? A projection every 3 years is fairly frequent because every projection involves vast resources and manpower. We started the consultations last year, and then early next year, or even we will need the middle of next year before we will need time up to the middle of next year before we can announce the findings. So the current approach seems appropriate. On changes halfway through on a rolling basis, that may not be the best way approach. On the waiting time for public outpatient care, this has to do with the HA in particular, but our manpower projection does not adopt the waiting time as a metric. That's because the projection is not about how many professionals the HA will need. Instead, it's about how many people Hong Kong will need. The HA can decide how many professionals they need for particular posts like nurses or doctors. We're now at 12:38 p.m. 5 members are still waiting to speak. I will extend the meeting by 15 minutes. Ms. Jovi Chen. Thank you. I want to discuss the manning ratio. Footnote 2 in the paper says that only 40% of the registrants are practicing in the public sector. The hospital authority is under huge strain because the HA looks after 90% of the serious patients and inpatient, but they only have 40% of the doctors and nurses. That's why public hospitals are overwhelmed. The government commits vast resources to the training of doctors every year. That training is heavily subsidized with public money. We're not trying to force graduates to stay in the public sector. But since we are performing a projection, what can we do about this asymmetry in manpower between public and private healthcare so that we improve the quality of care? Now, I also have a suggestion. I consulted trade unions about this healthcare manpower projection. The trade unions highlighted the crux of the matter. It's not about not having enough workers, it's about mismatch. The core issue is that we have a serious shortage of the non-medical staff, such as the patient care assistant and the ward managers. Now, for a ward manager, you can hire 2 frontline nurses for the pay of a single patient care manager or ward manager. The paper says the government will adopt the views of the industry so that we can produce results that can meet people's needs. I hope the Secretary will consider consulting the trade unions that are members of the FTU. Secretary. My team is aware of the point raised by the member. On the asymmetry in the manpower between public and private healthcare, we have less than half of the doctors and nurses, but we're looking after over 90% of the inpatients, especially those with serious conditions. Therefore, emergencies, for serious and acute conditions, the HA looks after those patients. That's for the public healthcare system. Many factors are at play. There are push factors and push factors, push and pull, for professionals to decide whether to stay in the public sector or go private. I myself have been in the public sector for a while. People in the public sector have this dedication to serve. Their work conditions and their pay may not be the best, but they are dedicated to service. That's the key factor. Of course, we're not saying this should continue just because of their dedication. Much has been done by the hospital authority to improve the working environment and also opportunities for further studies. At public hospitals, there are also innovation projects. We just launched the Chest Pain Center, for example. That shows our colleagues that there is room for further advancement in their careers. Over the past 4 years, the wastage rate of public healthcare professionals have fallen, but we're not complacent. We hope more healthcare professionals can join or stay in the public sector. On patient care assistants and ward managers, we understand it is an issue. It is an issue when the rates are high, and we're working on training to minimize the wastage rate. Next, Mr. Duncan Chiu. Many assumptions are involved in healthcare manpower projections. One factor is technology. AI is moving at breakneck speed. There may be sudden breakthroughs in medical devices or other AI-based tools, and that can result in huge savings in time. We may need way fewer workers. A projection is done every 3 years, but much can change in 3 years' time. Can we really keep up with the technological change? Most of the bodies consulted for the projection were healthcare bodies. How can we ensure that we have some objectivity in the process, maybe a new technology can emerge and then we will need way fewer optometrists. That is assuming such a breakthrough emerges. Are we consulting widely enough for us to keep track of the technological change? Paragraph 9 mentions extra training places. I support that. We are committing $30 billion to this. It does not have a breakdown. It simply says enhancements and upgrading facilities. Have we set aside money to procure cutting-edge medical devices? There are surgery robots now. Maybe the medical students will have to be trained in the use of such devices. Have we set aside money to buy the latest devices? Thank you.
Secretary, thank you. We do see rapid developments in technology, say in AI and robotics. The hospital authority is actively keeping track of the latest technologies that can be used in smart healthcare and smart hospitals. We do want to make use of them as soon as possible. The hospital authority has digitalized medical records as well as diagnostic images, and AI can be used to analyze the diagnostic images. It has greatly enhanced efficiency for analyses made by medical practitioners. As for whether it will greatly change the demand required of medical practitioners and other medical professions with the triennial cycle, I would say for one to undergo medical training and additional training for a specialist, it would mean for 6 years of training. And if technology will affect certain professions, we can perhaps provide conversion opportunities. For example, those working in diagnostics, they don't only work in diagnostics, they may provide intervention therapy. So I believe the hospital authority will deploy manpower to the right areas to make good use of their talents. As for the $30 billion, it is for the 3 universities to undertake works to provide facilities for, say, classroom training and laboratories. The 3 universities will make proposals on the works to be undertaken and how many of them would involve, say, medical devices. As you can see, there are rapid developments in technology. I would say the $30 million is not specifically for the procurement of medical devices. They're mainly for works. If capital is needed by different universities, there are different channels for them to obtain funding. Thank you. Mr. Chang Ho-feng, thank you. Right now, I think there is a misbalance of healthcare resources between the public and private sectors. If we subsidize an engineering student, it would be 500 to 600,000. But then for a medical student, the subsidy would be over $3 million. People are paying taxes to train medical students so that we don't have to have a long queue in the public healthcare system, but then we still have a long queue. For first year places of bachelor's degrees, we have now increased the number of training places to close to 2,100. The government is also subsidizing the universities in enhancing healthcare training and teaching and learning facilities. But right now, we only have 40% of the graduates working in the public sector. With taxpayers paying over $3 million to train a single medical student, over 60% of them work in the private sector, and some may not even practice medicine. Of course, they have the freedom to choose what they do, but then we have to consider how medical students are trained on public money. In the latest round of healthcare manpower projections, will we set a requirement for graduates to study or to work in the public sector for a number of years? Otherwise, they would have to pay back some of that public money. We also need to make sure we retain the talents, because otherwise we are just subsidizing the private sector. Thank you. Secretary. I thank the member for making a comparison to engineering students. For different areas, university courses are subsidized, especially subsidized by those subsidized by the UGC. As you said, for an engineering student, the government would subsidize an amount of around 600,000, but then they can work right away, and a lot of them will work in the private sector. There is no such requirement for them to work in the public sector. There is no requirement for the students to pay back money to the government if they don't work in the public sector. As for the medical sector, there's no requirement for medical practitioners to serve in the public sector, but then graduates of medicine are actually special in a way because they would have to work as an intern for a year in the public sector, and over 80% of the medical practitioners become specialists, and they would have to undertake 6 years of training, and they would often undertake this training in the public sector. They form pillars of the public healthcare system. Without them, hospitals will not be able to provide the requisite services. I would say medical students are trained for long, and they do receive great subsidies for that, but they provide 1 + 6 years of training, most of them, in the public hospitals. Some do not practice medicine in the end, indeed, but I think they are just a minority. We do encourage more graduates to stay in the public healthcare system. Thank you. Mr. CUHK. Thank you. I heard what Mr. Chang Ho-feng said about there being a long waiting time in the public healthcare system, and many citizens know this. Actually, because Hong Kong has a really good public healthcare system, most citizens wait for public healthcare services. I think with adjustments to the public healthcare system, more people will go to the private sector. I think that is better than us trying to increase manpower, because that cannot be done in the short term. I agree with what Professor Low said. For students studying medicine, even though they are subsidized, they still have the freedom of choice. We are concerned about the supply simply because we have a shortage. And in fact, it is said in 2040 we will have an oversupply of dentists. At present, I heard many dentists say they face great pressure. They have seen a serious decline in business because many citizens are going to the Greater Bay Area mainland cities for dental services, including scaling. So they want to go back to work in the public sector. But I'm still concerned about the shortage of dentists at this moment, even though we may have an oversupply in 2040. I can see in paragraph 14 that we have 1,000 odd places in shortage of dental hygienists. But I think with the decline in business, we may have less of a demand for such professionals. We need to make sure we have good matching of the demand and supply. Thank you. Secretary, I think Mr. Shu's concern, I would say with medical reforms, it would complement the manpower initiatives in healthcare. We want to make sure we develop as a medical innovation hub providing high quality healthcare services. For dentists, 90% of the dentists work in the private sector. Only 10% of them work in the public sector. And in the public healthcare system, we mainly provide preventive care as well as emergency care. We do see some changes in the market. As the member said, some citizens now opt for services in the GBA mainland cities. There are some short-term fluctuations indeed, but as I said, it would take time for adjustments in manpower to be effective. Right now, we have 90 graduates in dentistry every year. So there is some sort of lag in any adjustments in manpower. But we do think in the long term. We also implemented other reforms. We have, instead of taking a treatment-oriented approach, now take a preventive-oriented approach, which is why we want dental hygienists to play a more important role. They can help with preventive care rather than dentists, and dentists can focus on other services. So we do cover this in our projections for dental hygienists. As for our integration into the Greater Bay Area, whether it would affect the supply and demand for dental care professionals, we have included in our projections. Thank you, Chair. I want to ask if we will end the meeting at 1 p.m. sharp, or is it the case that we can extend the meeting to after 1 p.m.? I will try to extend the meeting until after I've spoken. I do support this. In that case, can I speak for a bit longer? I would like to raise 2 more points. All right. Well, we do have some patients that can go to the private sector for services. They go to the public sector, and many of them have taken out insurance, but they don't know how to make good use of insurance. I hope that we can do better publicity so that people don't waste their insurance and seek services from the public hospitals. I think you can enhance publicity in this regard. We had a shortage of medical professionals, so we allow admission of non-local practitioners. In the past, we supported such initiatives, but this year I heard more than one graduating students, well, in particular nurses, they have seen some changes before many hospitals would be vying for them. and now it's not as easy. I do support importation of manpower and specifically for professionals, but we need to consider this. Thank you, Secretary.
呢個問題
On medical insurance, for voluntary medical insurance, we already see a huge number of policies. The member used the phrase letting the insurers benefit. He said this. For someone already with insurance coverage, and then this person still goes to the public health hospital for subsidized health care. I'm glad to be asked this question. We can have a discussion about that. On non-locally trained healthcare workers. This is an option available only when we do not have enough locally trained professionals. Or nurses, I don't understand how this person can say they struggle to find a job. So the story is that this person said former graduates were approached by hospitals with offers, but they don't see the same attempt this year. I'm sure this nursing student can find a job. I just want to pass on the message. There are only roughly 500 imported professionals. There are 35,000 nurses at the hospital authority. The imported nurses only make up 0.7% of all registered nurses in Hong Kong. That's not even 1%. So you cannot say imported nurses are threatening the jobs for local nurses. It doesn't work. I hope nursing graduates can join the hospital authority. Chairman, just one more remark. That's all from me. Thank you. Now, some questions from me. Have we considered the impact of people going to the mainland for healthcare? After COVID, more people went to the mainland for healthcare, so that's becoming a major factor. I know private doctors and hospitals were consulted, but how do we quantify the information from the private sector? We also have professionals like speech therapists, audiologists, and psychologists. There are 5 kinds of such supplementary healthcare professions. We don't have the data, and that's why they were not part of the projection. Will we include these professionals in our projection? Now, your first question about people going to the mainland. The mainland has made huge progress in healthcare. People trust the mainland's quality of care. We want to give people the option. We also have to be mindful of whether our healthcare professionals are also going to the mainland. We will take this factor into account. So going to the mainland is not just for the patients, but also for the workers. But we also have incoming talent in healthcare from the rest of the GBA. It's a two-way process. We can deliver better care as a result. and we will give people more options as a result. On the second question, our health statisticians can take the question. Now, on the register of accredited healthcare professionals, these professions are not subject to statutory registration, so we don't have the data. We don't know how many there are. We maintain a risk-based approach. And we are looking at which of these 5 professions may warrant statutory registration. Once such registration applies to these professions, we will consider taking them or putting them in the projection. But for this round of projection, we will not include the 5 accredited professions. Now, over to my colleague, Dr. Pauline Wu. Now, for data from the private sector, the data covers age groups and the gender of patients, and also the way the private sector operates is very different from the public sector. That's why we focus on the population-driven demand. We also include the different age groups and the sex of the workers in the private sector, and then we'll quantify the information. Now, for day procedure centers and imaging centers, they also have data. Will we include such factors in our projection? So we will take that into account for the volume of service. Just then I was talking about the manpower. We consider the data on both fronts. Thank you. Anything to add from the Secretary? No. So that concludes this item. Any other business? No other business for today. I adjourn the meeting here. Thank you.